This lesson is about acid-base imbalances and specific respiratory acidosis versus respiratory alkalosis. Let's compare the pathophysiology of respiratory acidosis versus respiratory alkalosis. And remember, these acid-base imbalances are always happening with your patient behind the scenes, so it's never the reason why your patient is actually admitted. Some values for the NCLEX you'll have to memorize, and blood gases are going to be one of them. Let's review those. A normal pH is 7.35 to 7.45. If you want to remember the CO2, just drop those 7s, 35 to 45. For bicarb, just remember 2 plus 2 plus 2 is 6, 22 to 26. Now, these are going to be your normal blood gases when your patient's respiratory system is functioning, when your patient is breathing 12 to 20 a minute and their kidneys are working. So let's look at what's irregular, starting with respiratory acidosis. With respiratory acidosis, keep in mind that our normal lung function should be oxygen in and CO2 out. With these patients, they're going to be hypoventilating or breathing slow. So think respiratory acidosis, breathing slow. When we're breathing slow, we are holding in more CO2 in the blood. Now, this CO2 combines with water and it becomes carbonic acid, which is why our body is in an acidic state. Now, let's compare respiratory alkalosis. In this situation, remember, we are hyperventilating. It's the exact opposite. So our patient is hyperventilating, they are breathing fast. When they are breathing fast, it's going to blow out the CO2 from the body. There's going to be less CO2 in the blood, and we're going to have a lack of acid, making our body in a base state. Now, if you can't remember which way the pH goes, just look at my image on the right. Acidosis, look at that D, drops down. Versus alkalosis, that pH kicks up. Now first, let's look at the etiology of respiratory acidosis, which again, we're breathing slow. This is going to be anything that makes our patient hypoventilated. We can compare acute respiratory acidosis to chronic. Let's look at acute first. With acute respiratory acidosis, our patient can have an airway obstruction, so I'm thinking my patient is choking, or maybe they aspirated. My patient can have a chemical depression, so I'm thinking a patient that overdosed on opioids or alcohol abuse. Or maybe my patient has weak lungs, so I'm thinking Guillain-Barré or a spinal cord injury. Either way, with any of these presentations, my patient is going to be hypoventilated, breathing slow, or having poor gas exchange. Let's look at chronic respiratory acidosis. So we want to think of chronic as constant. These happen over time. So my patient who is obese, maybe they're hypoventilating because they don't have room for their lungs to expand. Maybe they have an obstructed pulmonary disease. So thinking COPD, emphysema, these are chronic changes. If your patient is in a chronic respiratory acidosis, but your question does not talk about symptoms, there's no intervention. These patients are used to being in a state of respiratory acidosis. We're continuing to monitor. Now let's compare the etiology of respiratory alkalosis, which is going to be anything that makes your patient breathe fast or hyperventilate. This basically looks like a panic attack. There can also be pulmonary conditions. So if you think of pneumonia, I have poor gas exchange. With an asthma exacerbation, I'm clamping down, I'm breathing fast, or even a pulmonary embolism. Now keep in mind patients that have a fever in a hypermetabolic state, so they're going to be breathing fast. Patients that go on a hike, maybe they live in a mountainous area, so high altitude, they're going to be breathing faster because they're not getting enough O2 in from that high altitude. And it can be from an improper ventilator setting where maybe we have to turn that rate down. Let's compare the clinical features of acidosis, which is hypoventilation, versus alkalosis, which is hyperventilation. Respiratory acidosis, breathing slow. If I'm breathing slow, I'm going to be holding in more CO2, which means my patient's going to be hypoxic. Now think of hypoxia, you're thinking of confusion, agitation, lethargic, drowsy. They may even complain of a headache. My patient with respiratory alkalosis, hyperventilation, breathing fast, again, they're going to look like they're having a panic attack, lightheaded, dizzy, confusion. Think about when you're panicking. Your heart can race. One important fact with respiratory alkalosis is to remember calcium imbalances. This patient is going to have low calcium. So you're thinking of things like tetany, which starts out as numbness, tingling around the mouth, extremities, muscle twitching. Late signs of either acidosis or alkalosis are going to end in seizure and coma. So it's really important to figure out these clinical features and assess them right away. Catch them early. Let's talk about compensation of respiratory acidosis or alkalosis. Now remember, our two organs involved in acid-base balance, lungs versus kidneys. So in respiratory acidosis, remember we're breathing slow, we're hypoventilated, that pH is kicked down. Our kidneys are going to respond by secreting more H+ in the urine. And they're also going to reabsorb bicarb, which is that base. As our body becomes more base, this is going to pull up our pH into the normal range of 7.35 to 7.45. Now let's look at respiratory alkalosis. Now our pH is kicked up. Our kidneys need to respond by reabsorbing acid. We're going to stop that bicarb production, and hopefully that bicarb reduces, which again is going to pull down our pH back to normal. Let's compare nursing interventions for respiratory acidosis versus respiratory alkalosis. Keep in mind that our healthcare provider is going to treat that underlying condition. Remember, this is not a diagnosis. Acid-base imbalance happens in the background. If our patient has respiratory acidosis, they're breathing what? Slow, hypoventilating. So we're going to have to improve that airway and breathing. Don't forget to put the head of bed up. We're also going to be suctioning if our patient has a copious amount of secretions. We have to open that airway. They may need supplemental oxygen. Medications are going to be based on the underlying diagnosis. So if my patient had an opioid overdose, maybe they would get Narcan. If we don't catch these for our patient early, they could end up with possible mechanical ventilation. Now let's talk about respiratory alkalosis interventions. Again, the healthcare provider is treating that underlying condition, but we need to improve that airway and breathing. These guys are breathing fast. They are hyperventilating. They're going to need oxygen. They're going to need medications based on the diagnosis. Are they having a panic attack? Maybe they'll have benzodiazepines. One tip that I can give you is to encourage slow, deep breathing, but do not use a paper bag. Now, this is because even though the patient can rebreathe CO2, they're not getting enough oxygen, which could cause them to become hypoxic. With either of these conditions, we need to monitor ABGs, we need to maintain our IV line for fluids, and constantly replace fluid and electrolytes. Now let's summarize respiratory acidosis. Look at the image on the right for me. We're going to start with pH, and that pH is going to drop down. It's going to drop down below 7.35. This is how we know we're in acidic state. Because our patient is breathing slow, they're hypoventilated, we're going to see that CO2 high. It's going to be over 45. How is the body going to try to compensate for this? It's going to be the kidneys. We're going to eliminate hydrogen, which is an acid, and we're going to retain bicarb, which is a base. Now, the kidneys are slow and they compensate slow. So this is why nurses have to act fast. Don't forget to support that airway and breathing, and we could possibly have to push sodium bicarb IV, giving the body more bicarb quickly. Let's summarize respiratory alkalosis. Now remember, in alkalosis, we're going to start with that pH. Look at the image on my right. My pH is kicked up. It's going to be over 7.45. Now, because my patient is breathing fast, we're going to be blowing off CO2. So that CO2 is going to be low. It's going to be under 35. How are the kidneys going to try to compensate? They're going to hold on to acid in the urine in the form of hydrogen and acid. We're going to stop making bicarb, which is a base. And remember, the kidneys are slow, so nurses have to be fast. We're going to encourage our patient to reduce their breaths, slow down breathing if they're awake. If our patient is on a ventilator, then that respiratory therapist is going to come in the room and turn our patient's respiratory rate down, bring them back to acid balance, which is 7.35 to 7.45.